So the other important thing from our perspective, and I don't think we class as a rural area anymore, but the death rate from prostate cancer is about 20% higher in non-metropolitan areas. And I think that is literally due to decreased public awareness, decreased access to healthcare. It's a fact. I know for a fact, though, however, that Port Macquarie is very much in line with the metropolitan centres, I think, because we are so well serviced medically, generally speaking. So I think it is a myth that men die with prostate cancer, not of it. The problem with it is it's a very diverse disease and it's generally slow growing. And that's part of the difficulty in that prostate cancer, we generally say to men, all right, if we diagnose prostate cancer in you and you do nothing about it, it'll probably take 10 years to kill you. In most situations, there are exceptions. There are really aggressive types of prostate cancer, which thankfully are quite rare. But for most men, it will take a long time. And so it gets harder and harder as, you know, you meet very healthy 70-year-olds and even 80-year-olds who are likely to live into their 80s and 90s. You don't have that crystal ball, so it can be difficult to know what to do in older men, whether you should diagnose it and whether you should then treat it or not. So this is a really important point, that early prostate cancer has no symptoms. Remember I said benign disease is a central disease that affects the urethra, it affects your urination, it causes the symptoms. Prostate cancer typically is a peripheral disease. It's on the outside of the prostate. So early prostate cancer doesn't impinge on the urethra. You've got to wait until it enlarges significantly. So if you've got symptoms, it's probably due to the benign or non-cancerous disease rather than the prostate cancer. So the next slide is a cross-section of the prostate. And there's the urethra in the middle, and BPH, that's benign prostate hypertrophy, the non-cancerous prostate cancer. And here is the area of prostate cancer out here. This isn't going to cause any symptoms. It's like early breast cancer, like early any cancer. They don't cause a problem unless they press on something. And testing is imperfect. PSA is an imperfect tool. PSA can be high, and you can not have prostate cancer. In some situations, PSA can be very low, and you can have a very aggressive type of prostate cancer. It is a great test, but it's not perfect. So sometimes we see men with high PSAs, but they've been high and stable for very many years, and that often reassures us that prostate cancer isn't there. So we can't rely on it alone. We use the rectal examination for exactly that reason. Some men have low PSAs, but gee, they've got a hard lump in their prostate, or they've, and we do occasionally find prostate cancers there that are sometimes very aggressive. We've also, and things are changing all the time, we've also now got a very specialised type of MRI scanning which can help us. But early detection really gives us our only possibility of cure, because once it's spread, you can't cure it. You can control it, but you can't cure it. And it's controversial because having your PSA tested, and I'm sure there are men in the audience in this situation, you become very PSA focused. You become very obsessed by your PSA. It creates a lot of worry. It leads you to having biopsies that can have side effects. So there is a downside to PSA testing and to the screening of prostate cancer. And I'm going to talk a little bit about that controversy coming up. So it's pretty clear that PSA testing increases cancer detection and decreases cancer death rate. And there are lots of studies that show that. There are some that show it doesn't make a big difference as well, but the majority of them do show decreasing prostate cancer death rates. But the problem is that a lot of those men may not have died of prostate cancer. And prostate cancer, I think historically, safe to say, particularly in the United States, has been overtreated. A lot of men with what we call insignificant prostate cancers had treatment. So we had a lot of men having side effects for a condition that may never have troubled them. And that's the problem, and that's the issue. How many people are we treating for the lives we're saving? Is it worth it? And it does create unnecessary anxiety. And that's why you'll see mixed messages in the media, PSA testing not recommended. But I suppose, and I'll talk a little bit more about that, but I think I just wanted to talk about one of the things that helps us decide. And we grade prostate cancer. We give it a score out of 10, and it's something called the Gleason score. And the pathologist looks down the microscope, and they don't really call C1s and 2s anymore. The pathologists have all agreed the lowest number they see is 3, 4, or 5, least to most aggressive. And then they look for another area of prostate cancer in the biopsy specimens that we've taken, and they give it a score, and they might say, well, it's 3 plus 3 equals 6, 3 plus 4 equals 7, 4 plus 3 equals a more aggressive 7, etc. Higher the number, the more aggressive it is. Now, this is probably the most complex slide, and the reason I put it up, because it's really important to demonstrate what I'm talking about why it's controversial and why we have to be careful in who we treat. Dark grey is your risk of dying from prostate cancer. Okay, don't try and work out the graph yet, just accept that dark grey is your risk of dying of prostate cancer. Light grey is your risk of dying from other causes. All right? These are 55 to 59-year-old men in this column, gradually getting older up to 70 to 74-year-old men in this column. So, remember we talked about Gleason scores? Let's look at someone with a Gleason score 6 cancer, who's 65. 5 years after diagnosis, the chance that they would have died of prostate cancer is about 5 to 10%. The risk they would have died of something else is about 15 to 20%. Let's go out to 20 years after their diagnosis. So they're now 85 to 89. Their risk that they died of prostate cancer, about 25, 30%. Their risk they've died of something else, 20, 40, about 60%. So can you see that light grey is a lot bigger than dark grey? So can you see that these are the men that are not likely to die of prostate cancer? They're likely to die of something else. And as you get older, in your 70 to 74-year-old, you see even less dark grey. Can you all hear me? Less dark grey to light grey. Now, where on the graph is there more dark grey than light grey? Bottom left. Who have we got here? The young guys. 55, 59, 60, 62, and also the ones with Gleason 7, Gleason 8, 9 and 10 disease. So the patients with more aggressive disease, the younger patients, well, you know, a 55-year-old, if he's got an aggressive prostate cancer, by the time he gets to 75, he's got a 90% chance of dying of prostate cancer compared to, you know, 10% of dying of something else. So that's why I want to shift the focus of who we're sending the message to. Yes, it's a disease when you get older, but who are the people who've got most to lose? It's younger men with more aggressive cancers. You follow that?